Bismillahir Rahmanir Rahim. Our lecture today is about the crystal deposit disorder in orthopedic. This is the fifth lecture in the second term. And we're starting by the gouty. What's called gouty arthritis. Historically, neuromatic disease has had more impact on the affairs of man than gout. Throughout the history, there are reports of the great and good suffering, the agony of the what's called podagra, from the Greek word for the food trap. And the term gout derived from the Latin words which is called gota, meaning a drop, and a common explanation of acute gout in early times being the concept of the poison drop into the joint. Considered as a poison drop into the joint, leading to this problem. And Hippocrates clearly refers in his aphorism to the rarity of the gout in the premenopausal women and children. And this is really, till now, it's a fact. By definition, gout is a crystal deposit disease caused by deposition of the monosodium urate crystals in the joint and other tissue secondary usually to the hyperuricemia. This is the definition of the gout. And epidemiologically, it is a primary disorder in about 95% and mean idiopathic, and a secondary in a form hereditary, rare, and acquired myeloproliferative disorder like associated with leukemia or multiple myeloma, and so also with diuretic use and with renal failure. These are groups called secondary gout. And gout is the most common inflammatory joint disease in men with a peak onset in the 5th decades. Risk factor including the family history in about 30 to 40%, alcohol consumption and renal impairment and obesity. Atherosclerosis, hyperlipidemia, and hypertension are important associated morbidity, but not a risk factor. A second group affected by the gout, in whom the gout is a common and older females, invariably on diuretic. In both these groups, under the excretions of the urate result in the hyperuricemia. The onset of the gout in the men prior to the adulthood or in the women before the menopause is very rare and should raise the possibility of inherited disorder of the urate metabolism resulting in the overproduction. Why it is very rare in the premenopause? Because they consider that the periodic cycle decrease the urate deposit because of the blood loss and protein loss. And these include deficiency of the hypoxanthine guanine phospholipase transferase enzyme, either as a complex with X-linked Lesch-Dehan syndromes or a more commonly partial like the Kelly-Sigler syndromes. Prevalence of the gout varies widely but is increasing, and it has been estimated about 10 to 25 per thousand adulthood in the developed countries. In our society, it is similar to this number here. And uric acid is predominantly produced in the liver as the end product of the purine metabolism. Hyperuricemia is defined as a serum uric acid levels above 42 micromoles per liter in the male and above 36 micromoles per liter in the women. However, relative to the most primates and all the other mammals, here we have points like in the certain mammals, the level is usually controlled by what's called uricase enzyme. This enzyme that breaks down the urate and the allantoin, which is a more soluble and readily excreted, while this is not mechanism not occurs in the human being. The urate is the most abundant natural antioxidant. So the urate is not a very bad substance in the body, but it is very important because it's an antioxidant and may confer resistance to the infections. Recent studies have also examined a possible protective effect against neurodegenerative disorder by the urate crystals of urate. So renal excretion is a complex about the urate. About 90% of the filtered urate is actively reabsorbed by the urate transport proteins in the proximal tubules, and further excretion and reabsorption occurs in the distal tubules also. Hyperuricemia is a prerequisite for formation of the urate crystal, but the pH, temperature, and the presence or absence of the natural inhibitors are also important. Otherwise, all hyperuricemic patients would be constantly forming a crystal in the urine, especially. So that was called crystal in the urine, urate crystal in the urine. Stimulation of the NLP3 inflammation and other humoral and cellular inflammatory mediators by monosodium urate crystals result in acute gouty arthritis and neutrophilic synovitis. Chronic cumulative urate crystals formation in the tissue fluid leads to the deposition of the monosodium urate crystals in the synovium, in the cartilage, in the tendons, soft tissues, like those in subcutaneous tissues, resulting in tophi formation. Such occurs in the ears, was called tophaceous gouty arthritis, or on the elbow joint on the subcutaneous bones. Clinical feature: asymptomatic hyperuricemia is about 10 times more common than the gout incidence, and the majority of the patients with hyperuricemia do not develop gout. And the annual incidence of the gout is estimated to about less than 10% in a patient with serum urate crystal above 440. So not all hyperuricemic patients they develop attack of gouty arthritis. Only about less than 10% of them. 70% of acute gout affect the first metatarsophalangeal joint, and the so-called podagra, and other sites including the knee, the ankle, mid-foot, elbow, and wrist. Attacks often begin at night, and within a few hours, the affected joint become red, hot, swollen, and extremely painful. Gout is rarely just painful or uncomfortable, and the patient may be unable to walk or bearing a touch even the clothes on the toes. Systemic features such as fever, malaise occurs especially during the polyarticular attacks. So one of the differential diagnoses of the rheumatoid arthritis is the gouty arthritis. The natural history for the attacks settles within about 1 week, and often with a desquamation of the skin over the affected joints. Acute gout may also cause bursitis, tendinitis, and notable in the elderly, cellulitis of the lower limbs. Untreated masses collection of the urate tophi may be deposited in and around the joint, notable on the elbow and over the small joint of the hands and in the ear. In a joint, tophi result in erosive disease, what's called chronic gouty arthropathy. Chronic gouty arthropathy. How we investigate? By the way, not all the gouty attacks occurs in those hyperuricemic. Sometimes even the level below normal, some persons develop gouty arthritis. Even below. So that not all hyperuricemic develop acute attack of gouty arthritis. And by the way, not acute gouty arthritis occurs in the hyperuricemic patient. How we investigate the patient? Hyperuricemia remains the cardinal features of the gout, but levels may be normal during acute attacks. If gout is suspected, repeat estimation of the serum urate over a period of a few weeks can be of a great value, so that we must be checked several times during attacks. If it's normal, maybe repeat after less than 1 week or more than 1 week, and we may find it is high in second estimations. Serum urate is also useful when monitoring the effect of the urate level therapy, like hypourinuria. We must check it after 1 month and to see the result of treatment. So may repeat the reading if the patient with acute gouty arthritis and with normal levels or hypouricemic levels, we must repeat it. Also in those cases under treatment to see the result of treatment if we use the lowering agent in the treatment of the hyperuricemia. Radiographs are unhelpful in the acute attacks, either being normal or showing just of tissue. In chronic gout, erosive arthritis may be seen. Classically, there are away from the joint margin being punched out with a rounded or oval shape and overhanging edges. These are the classic picture of the gouty, chronic gouty arthritis. Like this one, you see, punched out lesions here. This is a classic picture, like as some these cut from the subarticular bone. And in acute gout, synovial fluid is highly inflammable with a white blood cell count over 2000 per cubic millimeters. Even when uric acid crystals are seen, the joint fluid should also be examined for the simultaneous presence of the other crystals, especially calcium pyrophosphate crystal, was called pseudogout, and should undergo gram stain and culture to rule out the infections. Here you can see this is bursitis and gouty tophi. Here the gouty tophi, and here the affecting of swelling of the first metatarsal pharyngeal joint. The classic diagram is classic picture of gouty arthritis. Here, radiological picture of the gouty arthritis of the toe, chronic cases, and here tophi, it's open to the skin, and this is desquamation of the skin, and here the crystal drop out, and here under light microscope we see the crystals, and under here under polarized light we see the birefringent. انعكاس الضوء يكون two types of the light, you see it, red and blue. birefringent انكسار يكون باتجاهين متعامدين, so that give two colors of these crystals. Well, in the polarized light they are strongly negatively birefringent. Here we under light microscope the crystal of one colors, here under polarized light two colors. See, this is diagnostic for gouty crystals. How we differentiate the gouty arthritis? By this tables you can see the gout differentiated from septic arthritis regarding the finding, the clinical pictures, and so on. The investigation you see, and synovial fluid reading, and so on. How we treat the gout? Acute gout, anti-inflammatory agent usually. Non-steroidal anti-inflammatory are the drug of choice for treatment of acute gout without comorbid disease. Example, indomethacin about up to 50 to 75 milligram twice daily, and or nabroxone about 5 milligram twice daily, or etoroxy about 120 milligram daily, and also the crescendo regime is employed usually using large dose at first, tapering over about 7 to about 1 week. Non-steroidal anti-inflammatory drugs are unsuitable for many patients with gout due to the renal impairment and congestive cardiac failure, peptic ulcer disease, or use of the anticoagulant drugs. So steroids are probably the best alternative, perhaps intra-articular if only one joint is affected, or orally or IM if the joint access is difficult or gout is polyarticular. Colchicine is also helpful, though limited by the gastrointestinal side effects such as diarrhea and nausea. Also, you remember one of the side effects of colchicine, retroperitoneal fibrosis, has been reported and causing ureteric obstructions. So keep in your mind about the chronic use of colchicine. Non-drug treatment, including resting, ice bath, and supplementation will help and will powerful analgesia. This is during acute attacks of the gout. Chronic cases. Patient educated is important in the management of chronic gout. Appropriate lifestyle modification, weight loss, and dietary advice such as reduction of the alcohol and the fructose consumption can be a powerful interventions. Also, in some patients with a gout, a decision may be made to offer a long-term urate-lowering therapy, like the high allopurinol. At first line of the urate-lowering agent are those that reduce the formation of the urate by inhibiting xanthine oxidase, and allopurinol is the drug of choice. As it is being introduced, it can trigger a paradoxical flare-up of the gout, so that if you use allopurinol, sometimes the patient comes to the clinic or to the doctors about the flare-up of the pain and the initiation of this treatment. So we advise them, if the pain exaggerated, reduce the dose or stop it temporarily and then resume it again. It should not be started until at least 4 weeks after the last acute attacks, and prophylaxis should be offered with lower dose of colchicine until the serum urate crystal is stable in the target range. Other urate-lowering agent drugs, like the uricosuric, increasing excretion of the urate at the kidney. In general, they are less effective than the allopurinol, and they are contraindicated in the urolithiasis. When we have a stone in the urate stones, crystal in the urinary system, this is contraindicated to use these drugs. What are the complications of the gout? Tophi formations. Chronic gout can lead to the deformities and destruction of the joint, arthropathy, and nephrocalcinosis is important because deposition with the calcium to produce a rocky kidney appearance on the X-ray, it will lead to the renal failure. This is very important. Nephrocalcinosis, not renal stones, but what's called like a glassy kidneys. Nephrocalcinosis and appears as a nephrogram. Nephrolithiasis, retrograde neuropathy, which will lead to the renal failure, and secondary osteoarthritis also occurs in these joints. Thank you, and we hope to see you later.